So in case of renal failure, what happens? There is accumulation of creatine in the body. Creatine becomes high. Now, apart from the exocrine action, there is an endocrine action. Like erythropoietin. What is erythropoietin? Is a factor which is needed for erythropoiesis. Okay, which helps in erythropoiesis. So in case of renal failure, if there is a history of renal failure in a family, you know the patient needs time to time dialysis and erythropoietin injection. And again another function is there, there is hydroxylation of with the active form, that is the inactive to active form of the vitamin D, that is hydroxylation process takes place in kidney. So in renal failure there is deficiency of the vitamin D. Vitamin D is absorbed here. Hydroxylation is at the kidney. So kidney has so many functions. Now what is the situation of the kidney? Kidney is situated in the posterior abdominal wall. In the paravertebral region. We know there is one, in the lumbar region there is one muscle, that is the psoas major muscle. So psoas major muscle creates a and that area is called the paravertebral gutter, which is occupied by this psoas major muscle. And over the psoas major muscle we will get and the kidney. Not only over the psoas major, there are other muscles, there is quadratus lumborum, and more laterally that is transversus abdominis. So it is present in the lumbar region, in the posterior abdominal wall, retroperitoneal structure. So it can be approached from the back also, kidney from the back. There is one parallelogram which is called Morris parallelogram. During our dissection or during our surface anatomy, we will know what is Morris parallelogram. It is so it is related to the lumbar vertebrae and also the 12th rib of the right side and 11 and 12th rib of the left side, they are also in relation to the kidney. Okay. So above we are getting the diaphragm, then we are getting the relation of 12th rib on the right side and 11 and 12 rib on the left side. Now, how is it directed? We can see the interior, but before that, how the kidney is directed. Kidney, you can see it from this diagram. It has got upper pole. This is the upper pole. which is directed upwards and medially. And it has got lower pole, which is directed downwards and laterally. So upper pole, it obeys the rule of two poles. One is upper pole and one is lower pole. Upper pole is directed upwards and medially, and lower pole is directed downwards and laterally. So the long axis is directed downwards and laterally. The axis means you can imagine one imaginary line from upper pole to lower pole, then that axis is from medial to lateral. From medial to lateral. Upper pole is nearer to the vertebral column, which is 1 inch away from the vertebral column. And the lower pole is around 3 inches from the vertebral column. And here we can find one concave area medially. You can find one concave area medially. This area, which is called hilum of the kidney. Hilum means window through which some structures enters or leaves. That is the hilum. We have got the hilum in the lung. The structures are either entering, there is bronchus, the different pulmonary artery, they are entering, and pulmonary vein, they are coming out. In case of bronchus, in case of lung, there is a hilum. So in case of kidney, this area is called the hilum of the kidney. That is how much away from the midline? It is 2 inches away from the midline. Whereas the lower pole, you can find the lower pole, that is around 3 inches away. So it is obliquely placed in the posterior abdominal wall. It obeys the rule of two, upper pole, lower pole. It has got anterior surface and posterior surface. The surface which is facing us, that is the anterior surface, and which is behind, that is the posterior surface. Anterior surface is more convex. How we can identify the anterior and posterior surface? When we will hold the kidney, it will be very difficult. So we can identify this one. The anterior surface is convex, whereas the posterior surface is plane. It has got different borders. We can find one convex border or outer border or the lateral border, and this is the lateral border. Another border we can find medially, that is the medial border. The medial border in the upper part is also convex. In the lower part, that is also convex. But the intermediate part, that is concave, which is nothing but the hilum of the kidney. Now, what is the position, exact position? The vertebral, the position is denoted by the vertebrae. From L1 or T12 vertebra to the L3 vertebra. On the right side there is liver. In inferior surface of the liver there is an renal impression, and due to the pressure effect of the liver, the right kidney is a bit at a lower level, whereas there is spleen on the left side which is at a higher level. So the left kidney is at a higher level. So from T12 vertebra to the L1, L2, L3, this is the area of the kidney. Now and the right kidney is at a lower level than the left kidney. Okay, why? Due to presence of liver on the right side. Okay. So if we draw a transpyloric plane below the xiphoid process that passes through the hilum of the kidney. Transpyloric plane is very important because here we will get the pylorus, here we will also get the hilum of the kidney. But right kidney is a bit lower level, whereas the left kidney is at the higher level. So transpyloric plane passes through the upper part of the hilum of the right side, whereas it passes through the lower part of the hilum on the left side. Now, what are the structures we can imagine in front and behind? Before that, we know this is the trans-cristal plane. The iliac crest, the highest point of the iliac crest, through which if we draw a line, that is called trans-cristal plane. And there is a relation between trans-cristal plane and the kidney. The lower pole of the kidney is about 1 inch or 2.5 centimeter above the trans-cristal plane. Okay. Now, what are the structures which are present in front? And what are the structures present in the behind? Here you can find there are several colors which are present on the anterior surface of the right kidney and the left kidney. Can you find? We can find the yellow color. The right kidney, there are 2 yellow color. One yellow color is on the top. That area comes in relation to the suprarenal gland. And another yellow area we can find near the hilum of the right kidney. This is in relation to the second part of the duodenum. Okay. Now another area in the anterior surface which appears to be orange in color, and that area, in that area we will get the peritoneum, and that area is related to the renal impression. In the inferior surface of the liver. In the inferior surface of the liver, we can get a renal impression. So that inferior surface of the liver comes in relation to that area, that the anterior surface of the right kidney. Now, below that area, we can find one pink area. We know there is ascending colon, then ascending colon in the right side, it then curves to the left side. There is a right colic flexure, and it is going as a transverse colon. So that transverse colon gives an impression here. The right colic flexure and the transverse colon gives an impression over the anterior surface of the right kidney. And just below that area is in relation to the jejunum. The coils of jejunum, they comes in relation to that area. So these are some relations of the anterior surface of the right kidney. Similarly, in the left side, we can find one area above and most medially, we can crescentic area that is in relation to the left suprarenal gland. Another crescentic area above and laterally we can get, which is been created by the spleen, that is called splenic area. Below that area, in the middle part, we can get a very extensive area that is yellow in color, that is being given by the body of the pancreas. And in between the upper crescentic impressions and what the body of the pancreas, that area comes in relation to the stomach. We know the stomach bed. In the stomach bed, we get the kidney. There are so many structures we can get in the stomach bed, like splenic artery, right? The left truss of the diaphragm, the body of the pancreas, kidney. So we are getting so many areas. So that area is in relation to the stomach. And similarly, we can get in the lower part the jejunal area in both kidneys, and another area which is colic impression, which is created by the descending colon. Okay. Now, how can you remember all this? Because in your examination, you will get the question that describe the anterior relation of the kidneys. If you can remember one mnemonic, in Bengali mnemonic, you can remember it. For the right kidney, that mnemonic is Sada hatir dam koto. Sada hatir dam koto jano? Jano na? Khub dami. Sada hatir dam koto. Sada means S. Suprarenal gland. Hati means hepatic impression. Da means duodenal impression. Koto means colic impression. Jano means jejunal impression. So if you can remember that mnemonic in Bengali, Sada Hatir Dam Koto, then you can remember the anterior relation of the kidney of the right side. Sada Hatir Dam Koto. Similarly, another mnemonic is there for anterior relation of the left kidney. Do you know that mnemonic? But if you know, you will not forget throughout your life. If you know just now, if you have some idea just now, you will remember it for your rest of your life. Shokha shokhir gaye paye jol keno? Shokha shokhir gaye paye jol keno? Shokha means suprarenal. Shokhi means splenic. Gai means G, gastric impression. P, pancreatic impression. Body of the pancreas. Jol cano means, that is the jol means jejunal impression, cano means colic impression. So these are some mnemonics. Actually it is actually carried forward from generation after generation. Our teacher was Sumita madam, Dr. Sumita Sarkar. Her son is a famous Bengali film director, Srijit Mukherjee. Do you know Srijit Mukherjee? And Sumita madam was my first teacher in anatomy, and she used to give so many mnemonics, and we can remember the anatomy very nicely. I can remember, I actually honor very much that lady. So these are the anterior relation or anterior, the structures which are present in anterior part of the right and the left kidney. Now what are the structures which are present posterior to the right and left kidney? You can see 11th and 12th rib on the right side, and on the left side, as if you are seeing this picture from behind. Okay, as if you are seeing it from behind. Okay, so on the right side only the 12th rib will come, and 11th and 12th rib on the left side. Okay, now you can get some vessels and nerve below the 12th rib. They are subcostal vessels and nerves. Vein, artery, nerve from above, below. Okay, so they are coming in posterior relation to both the kidneys. Okay, so these are the structures which are in relation to the posteriorly from above downwards. From medial to lateral, you can find one muscle most medially, that is the psoas major muscle. You can see psoas major muscle is here, quadratus lumborum muscle is here, and transversus abdominis muscle is here. So from medial to lateral, psoas major, quadratus lumborum and the transversus abdominis, they are coming in posterior relation. And also we have seen the branches of in the posterior abdominal wall, we have seen the branches of lumbar plexus. Can we remember? Behind the kidney in the cadaver, we have to lift the kidney to see the nerves. They are ilioinguinal and iliohypogastric nerves. So, from above downwards, on the right side, the 12th rib, on the left side, 11 and 12 rib, then we will get the subcostal vessels and nerves, then we will get the iliohypogastric and ilioinguinal nerve. From medial to lateral, we will get most medially, that is the psoas major muscle, then quadratus lumborum, and most laterally, that is the transversus abdominis muscle. Now, there are some coverings of the kidney. Here we can find most inside there is one covering. Most inside. That is the renal capsule. The renal capsule we can see that goes inside the hilum. This is the hilum through which this renal capsule, that covering which is in intimate relation to the kidney, that is the this is the renal capsule, and this renal capsule, it goes inside the hilum. Then just outside you can see one yellow layer, that is called, just outside we can find another layer, fatty layer, which is called paranephric fat. That is a fatty layer. Most inside one is capsule. Then another layer we are getting, where we are getting the fat, which is called perinephric fat. Then another capsule which can find, which has got anterior part and posterior part, which is called renal capsule or renal fascia. And most outside there is another layer which is called paranephric fat. From inside outside, most inside is renal capsule, then we will get perinephric fat, then more outwards we will get another layer which is called renal fascia, and most outside we will get some again a fatty layer which acts as a packing material for the kidney, so that kidney cannot move here and there. That is paranephric fat. Renal capsule, perinephric fat, renal fascia and paranephric fat. These are the coverings of the kidney. Now about the next slide was the circulation. না স্ট্রাকচার এসে গেছে, তাই তো? স্ট্রাকচারটাই না হয়ে গেছে। This is the macroscopic structure of the kidney. If we cut the kidney vertical section, we can get this is the structure of the kidney. Here we can find the outer cortex and inner medulla. You can see that Sarah has given a conical color. You can see this is the outer cortex and inner medulla. And this inner medulla is conical in structure, which has got base and the apex. This apex is directed towards the hilum. So, kidney has, inside the kidney we will get the cortex and the medulla. Medulla appears as a conical pyramids, okay, or medullary pyramids. And in between the pyramids, we can get again the cortical areas, which is called renal columns. Okay. So, outer cortex and inner medulla, and in between the medulla, we can again get the cortical matter. They are called the renal columns. Now, we can find the apex of the pyramids. They are directed medially and towards the hilum. And they open into cup-shaped structures. They open into the cup-shaped structures. Those cup-shaped structures, we can find the apex, they open into the cup-shaped structures. They are called the minor calyces. Okay. And 7 to 13 minor calyces unites to form again another cup-shaped structure, which is called major calyces. And 2 to 3 major calyces, they unite and forms this pelvis or renal pelvis. Again I am repeating, if we concentrate on the macroscopic structure of the kidney, we will find outer cortex, inner medulla. The inner medulla, within the medulla we will get some pyramidal or conical structures, which has got base is directed laterally, and the apex is directed medially towards the hilum. And the apex of the pyramid is also called the papilla. They are being accommodated within the cup-shaped area that is called minor calyces. And 7 to 13 minor calyces joins to form again another cup-shaped structure, which is called major calyces. And 2 to 3 major calyces unites to form the pelvis of the ureter. Now this cortex, we get in we know the nephrons. Nephrons are, what are nephrons? They are structural and functional units of the kidney. And these nephrons we can find at the cortex. Most of the nephrons are localized in the cortex. They are called cortical nephrons. And some nephrons are towards the base of the renal pyramids. They are near to the pyramids. Near means juxta. Near means juxta. They are near to the medulla, so they are called juxtamedullary nephrons. So there are two types of nephrons. One is cortical nephron and another group of nephrons which are located near the base of the pyramid, but they are definitely in the cortex. They are called juxtamedullary nephrons. Now the cortical nephrons are active. The major blood circulation, major excretion is related to the cortical nephrons. Juxtamedullary nephrons, actually they remain inert. They generally do not take part in function. Okay. And what we get, the afferent arteriole, glomerulus, efferent arterioles, they are basically, the blood is passing through the juxtamedullary nephrons. Cortical nephrons. And the cortical nephrons has got afferent artery, efferent artery. Afferent artery are, the diameter is more than the efferent arteries. So just remember, you can forget everything. Regarding the macroscopic structure, when we cut a section of the kidney, we get outer cortex, inner medulla. And in the cortex, we get the cortical nephrons, and near the medulla, we get the juxtamedullary nephrons. Cortical nephrons are generally remains active. When they fail, the juxtamedullary nephrons will take part of it. Now regarding the arterial supply, you can see the renal artery. The red one is the renal artery. It is coming from the abdominal aorta, which is one of the lateral branch of the abdominal aorta, that is the renal artery. And it goes inside, it divides into 4 to 5 segmental arteries, and they actually the pyramids are actually the lobes. Pyramids and the cortex, they forms a lobes. So divides into lower artery, then passes in between the renal pyramids, which is called the interlobar artery, which again divides into 2 arteries, which is called the archiform artery. From there we will get interlobar artery, from where we will get the afferent artery, which ends in the glomerulus, from the efferent artery, which ends in peritubular plexus, from there the intertubular artery, from there interlobar artery, then the archiform, from there archiform vein, from there we will get the interlobar vein, then segmental vein, then we will get the renal vein. Remember, forget it. Just remember, renal artery, 4 to 5 segmental arteries. From there we get lower arteries, interlobar arteries, everything. Then ultimately which ends in 4 to 5 segmental veins. These 4 to 5 segmental veins joins to form the renal vein. On the right side or left side, the right and left renal vein drains into inferior vena cava. আছে না আর আগে ছবিটা নেই আর নেই now we can see the right and left renal vein, they drain into the inferior vena cava. That much you can remember, that you should remember, okay? And you should remember another thing, on the left side, the left renal vein, in the left renal vein also we can get the drainage of the left gonadal vein. We can see the left gonadal vein, which also drains into the left renal vein, and also the left suprarenal vein, inferior suprarenal vein also drains into the left renal vein. So renal artery is coming from abdominal aorta, and renal vein drains into the inferior vena cava. Another structure we can find which is coming out from the kidney and coming down as a tube, and which ultimately drains into the bladder, urinary bladder, that is ureter. So in the hilum we can find renal artery, renal vein, and the ureter or the pelvis of the ureter. From anterior to posterior, the structures are, most anteriorly we will get the vein, then we will get the artery, and most posteriorly we will get the ureter, or pelvis of the ureter. VAU. Most anteriorly we will get the vein. Vein is thin walled, artery is thick walled, and most behind the tubular structure is nothing but the ureter, okay, or the pelvis of the ureter. Now, what is the nerve supply? Sympathetic from the actually sympathetic is coming from the thoracic region, thoracolumbar region, okay, from T9 to L1 level it is coming, and parasympathetic, actually those nerves are coming and entering into the abdomen as splanchnic nerves, and within the abdomen what we are getting? Celiac plexus, superior mesenteric plexus, inferior mesenteric plexus around the arteries, and from there, they are going towards the organ, that is the kidney, okay. Now about the clinical point. If there is obstruction of the ureter, the kidney gets affected, which is called hydronephrosis. Collection of urine within the, or the fluid within the kidney, that is the hydronephrosis. Next one is the renal stones, not very uncommon. Formation of different oxalate stone we can find within the kidney, that is the renal stone. Next is glomerulonephritis. You will know in pathology. And the last one is renal failure. In case of renal failure, that means when the actually the nephrons are getting affected due to any disease or any, like in diabetes, in hypertension. So the kidney is affected and it cannot perform that. What is the function? It actually excretes the toxic material. When it cannot excrete, that means the creatine becomes very high. Okay, creatine becomes very high, and there is electrolytes cannot pass out, like potassium cannot pass out. So there is increased potassium level in the blood. So during that time, renal dialysis is carried out. Renal dialysis, you will know in clinics. And there is another dialysis which is called peritoneal dialysis. Actually, the fluid is injected within the peritoneum. From there, another output is made through which the fluid is taken out, and ultimately the toxic materials comes out. So that is called peritoneal dialysis. Now we can find next embryological abnormality, agenesis, renal agenesis. We know it develops from ureteric blood. Okay. You will know it in one kidney might not generate, very common, or sometimes both the kidneys are absent in a child, renal agenesis. Okay. Sometimes there might be two kidneys in one side. There might be horseshoe-shaped kidney because two kidneys are connected with each other, which forms a horseshoe-shaped kidney. Okay. And I think it will be more evident in your embryology class. Now we can see the ureter. Ureter, actually it comes out from the kidney and it passes through the abdomen and the pelvis, and it is drained into the urinary bladder. So what is the length of the ureter? Ureter is around 26 centimeters, which starts from the pelvis of the ureter and ultimately it ends at the superolateral angle of the urinary bladder. Now it has got one abdominal part and we can find the abdominal part within the abdomen. When it crosses this area which is called the pelvic brim, it is called the pelvic part. And this is the abdominal part. It rests on the psoas major muscle. And how we can find the ureter in a living? When we open the anterior abdominal wall and we search for the ureter, how we can identify this ureter? There is active peristaltic movement of the ureter, continuous active peristaltic movement of the ureter by which we can identify this is the ureter in a living body. So ureter is related anteriorly with, on the right side there is duodenum, third part of the duodenum. There are some gonadal vessels passing in front of it. Root of the mesentery, they are coming in front. Posteriorly, it is related to the psoas major muscle and also the genitofemoral nerve and tips of the transverse process of the lumbar vertebra. Now up to this sacroiliac joint, this is the abdominal part, and in that sacroiliac joint, it crosses in front of the arterial diversion. One is external iliac and internal iliac. So it passes in front of the division of the common iliac artery, and it passes along the curvature of the greater sciatic notch, and it goes up to this spine. This is called ischial spine. So it goes up to the ischial spine. From the ischial spine, it comes obliquely forward and ultimately it ends in the superolateral angle of the urinary bladder. So, about the pelvic part, this is the abdominal part. We are getting the anterior relation. That means there are some gonadal arteries, root of the mesentery on the right side, and pelvic apex of the pelvic colon in the left side, and on the right side we are getting, right and left side we are getting the coils of small intestine in front. And on the medially we are getting inferior vena cava on the right side and aorta on the left side. Actually, to remember the relation, you have to see the cadaver. Otherwise, it is very difficult to remember. About the pelvic part, it starts from the sacroiliac joint. Part 1, it is divided into part 1 which ends up to the ischial spine. The second part from the ischial spine up to the superolateral angle of the urinary bladder. And the third part is within the bladder, within the musculature of the bladder. So pelvic part has 3 parts. One is from sacroiliac joint up to the ischial spine, from ischial spine to the urinary bladder, and within the bladder, that is the third part. And it is related definitely with the structures of the lateral pelvic wall, that means obturator internus. It is related to several arteries and veins like obturator artery, obturator vein. These are all relation. Obturator internus, they are related laterally. Posteriorly, it is related to the internal iliac artery. And this is the area in female, this area is occupied by ovary in ovarian fossa. So, this ureter forms the posterior boundary of the ovarian fossa. I can feel this. It is very difficult for you to remember all this. But just listen. There is one ovarian fossa where we get ovary, which is being bounded behind by this ureter. That much you should remember. Then it passes over a muscle, which is a sloping muscle, which is called levator ani. So below this pelvic part, which is obliquely coming from ischial spine to the urinary bladder, below this part we will get the levator ani. And in case of female, we will get one ligament from lateral pelvic wall up to the uterus. That is the Mackenrod's ligament. And one artery, that is uterine artery, which remains on the lateral side. Then it crosses from above and goes medially. Uterine artery is coming from the internal iliac artery, anterior division of the internal iliac artery. It first remains lateral relation of the ureter. Then it crosses the ureter from above. Then it goes medially. And this ureter is around 1 inch or 2.5 centimeter away from the cervix of the uterus. Very important during hysterectomy. During hysterectomy, one can injure ureter. You can forget everything, every relation, but you cannot forget one relation. That is the relation of the cervix of the uterus with the ureter. Ureter remains, you can find ureter. In case of female, there is uterus and cervix. From the cervix of the uterus, ureter is only 1 inch away. Ureter is 1 inch away from the cervix of the uterus. That is the most important relation. You can forget each and every relation of ureter. But there is a very important relation, that is ureter is 1 inch away from the cervix of the uterus. So during hysterectomy or removal of the uterus, when we are putting the clamps over the uterine artery, we may affect this ureter. Within the clamp, we can clamp the ureter also, and we can cut it. So that relation is very important, because during hysterectomy, we should be very much cautious, because ureter is only 1 inch away from the cervix of the uterus. Okay? And this uterine artery crosses from lateral to medial, this ureter. So during putting our clamp over the uterine artery, we should not include ureter. Now, we can see there are some constrictions of the ureter. There are major 3 constrictions of the ureter. One is at the beginning, that is at the pelviureteric junction. This is the first constriction. The second one is at the pelvic brim, or when it is crossing the division of the common iliac artery, or at the level of sacroiliac joint. Second constriction. And the You can see the third constriction which is being created by the vas in case of male, and fourth constriction when it is passing through the bladder. We cannot remember the five. You may forget the five uterine constrictions, ureteric constriction. Just remember the pelvic-ureteric junction at the level of crossing of pelvic brim, and another constriction at the entry of the ureter in the urinary bladder. There are three major constrictions. Why these constrictions are important? Ureteric stone can come down. The renal stone can come down through the ureter and get impacted over these ureteric constrictions. So the ureteric stones we can find at the pelvic-ureteric junction, we can find at the crossing, that means at the pelvic brim, and another we can find another area where we can find where it enters into the urinary bladder. Okay. Now, ureter is supplied by the arterial supply. It is, when it is coming down, it is getting supply from various arteries. When the ureter is coming down, like it is coming from the direct branch from the renal artery, suprarenal arteries. It can come out from the lateral branches of the abdominal aorta. It can come out, the supply can come out from the internal iliac arteries, from the branches of the internal iliac arteries, that means superior vesicle, inferior vesicle arteries. In case of female, it can come from the uterine artery. And also there is peritoneum. From the peritoneal vessels can also supply these ureter. Peritoneal vessels, the vessels present in the peritoneum also can supply this ureter. So unnecessary separation of the peritoneum during the surgery is not acceptable. It can affect the blood supply of the ureter. The arteries are forming ascending and descending branches, and linear we are getting arterial supply. About the structure, it has got outer fibrous coat, then muscular coat, then we get the mucous membrane. Regarding the muscular coat, we get outer circular and inner longitudinal muscle in upper part of the ureter. In the lower part of the ureter, we get outer longitudinal, inner longitudinal, and in between circular muscles. Lymphatic supply. In the abdominal part, from here, it will go to the para-aortic lymph nodes. From the pelvic part, it will go to the common iliac group of lymph nodes and iliac group of lymph nodes. Nerve supply, sympathetic from T11 to L1 level. Parasympathetic, actually pelvic splanchnic nerve from the S2, S3 and S4 segments. What are the clinical anatomy of the ureter? Most important, we may affect the ureter during our hysterectomy operation. First clinical anatomy. We can cut the ureter, unfortunately. If we do not know the anatomy of the ureter, we may cut. Second is ureteric colic. This ureteric colic goes from loin to groin because it is being supplied by the sympathetic, it is carried out by the sympathetic nerve. It is from T10 to T11 level to L2 level. From T10 to L2 vertebra, the spinal nerves are coming. Okay, and through the spinal nerves, the sympathetic nerves are coming and they supply. So, the pain is referred from loin to groin area. And it is carried out by the sympathetic nerves.